systems across the country to really, invest in this. And I understand there's been a lot of work done, especially in previous years, on this value-based care, value-based medicine. But health insurance companies have a huge financial incentive in keeping people healthy. Not all the incentives work that way in the health system. But how do we work with those massive incentives and motivate people in the system where they're getting paid more? I mean, let's be honest, a lot of people in the system do make money from illness. That's a fact, and that's a simple fact that somebody's a doctor, in a sense, like they're making money. But how do we create extremely powerful incentives so that doctors are not only kind of thinking about how to treat patients? I mean, somebody mentioned that 50%, Bob, was that you? 50% of doctors in this study did not tell their patients, to stop smoking. I mean, the same thing. I would apply this probably to dietary and lifestyle interventions. I mean, I know somebody who just got diagnosed with a major, cardiac issue, and nothing was mentioned about changing one's diet or lifestyle. Nothing, not a thing. Not even go consult with a dietitian or something. And we hear the same thing over and over with people who have diabetes from their endocrinologists and so on. So I think we really need a radical change in the way the system is structured, and that's kind of to the point that what we're doing is really approaching things from the bottom up. We're organizing communities, we're getting them motivated and excited, and yes, some changes coming from the bottom up, but we need sort of a very, very powerful intervention from the top down to change the financial structures and the laws and everything else, and to have that full saturation of a preventative universal healthcare system.
Okay.
Well, I was just going to make a comment. I went to the American Diabetes Association just this past year, and there is a research group out of Boston headed by Samir Malkani who is interested in this. Mainly, the research that they've been involved with is looking specifically at hemoglobin A1C, but they've tested out several models, one of which is they bring a patient into a room, and that patient gets 30 minutes with their endo, 30 minutes with the dietitian, 30 minutes with the pharmacist, 30 minutes with the medical assistant, and then they commit. They actually write something down committing that they're going to take everything that they learned back, carry it out, and then they tested them a year later and found they were able to achieve a 1-point reduction in hemoglobin A1C. They've also studied similarly where they had a group of patients in a room and everybody talks to each other, and it's like mass clinic, everybody with the same symptom, everyone talks to each other, so that's social study, and it worked. The single barrier in carrying that out was getting reimbursement for all those things once you actually try to implement it into clinical practice. So you're right, it really needs to have some, a big movement in that direction in order to carry out some of these things, and they're multifactorial. It's like Dean Ornish needs a social influencer. Who knows how to, get that going, because it's an extreme program.
Well, and also,
how do you get someone enthused and then sustain?
Sadly, now as a country, we're thinking about how to increase fruits and vegetables, meaning how to increase French fries in our diet, for a high school kid. I'm not mentioning any names.
Okay, before we get too cynical, I think this conversation can go on forever. Can we continue the discussion outside? Would that be okay? I want to be mindful of everyone's time since it's 6:30. But thank you so much. And please, there's food outside. Let's continue the conversation. I think the number one message is that we need to continue with the social influence. So let's keep it going.
It's on the bandwagon.
Well, it's much more right now about oh no, I was only going to say that maybe what we're eating could have some impact.
As I mentioned,
You know what, Brian? Brian, oh yeah, these is electronic. Brian, he emails them out with the invitations.
Yes.
Oh.
Yes. Yes, I will be able to email them. Okay, you would like a copy? Okay, yes, perfect, will do. Yeah, okay. Yes, will do. Thank you.
It always ends this way. No, it always ends this way. Okay.
You too, and maybe.
Oh, thank you.
Yes, I have to take a, you know, that is.
Take a picture and send it out.
Let's say 1, 2, 3. 1, 2, 3.
I mean, it's
What are you gonna like real?
So that you should get ready.
Oh, I can take a picture. I can take the photo. I can take the photo.
We need the
Are you aware that there are two medications for acutely medically ill patients instead of low molecular weight heparin?
Close, ready, 3, 2, 3, 2,
So from the approved end of October, so when you have patients who are just have stroke or heart failure,
Exactly.
hospitalized, you're
Yeah.
because they have low molecular